we go. Sorry about all that.
I don't know what's up with those little boxes or why they're showing up there, but
there is a way to switch it, Ken. I think, see that with the 3 dots at the bottom, right below your slide. If you click that, you can click out of, yeah, there you, oh, no. Well, I mean, either way, we can roll with that if that's all you can pull up.
how about if I try screen sharing? Can you see it now?
You see it as long as you, yep, as long as you put it in presentation.
I got the same thing going now.
Yeah. Are you okay with that? I think it.
I am.
Yeah.
Your high presenter view.
Yes, high presenter view. Yes. Oh.
And now slideshow.
It won't let me go to slideshow.
Huh.
It's always something, isn't it?
It is. What we need tech.
Yeah, I don't know.
How about if you close the little clipboard on the left by hitting the X and close the format background on the right by hitting that little X?
Close the little clip. I don't see the clipboard.
Oh, left column.
Yeah.
And right column. And we might want to stop the record and then start it again and then have him introduce himself, please.
Good morning, everybody. I'm Ken Norton, the Executive Director of NAMI New Hampshire, the National Alliance on Mental Illness. And thank you for having us here today. For those of you not familiar, now I'm trying my second slide and it's not showing it on your screen, I think. Is that right? Are you still?
We're seeing your first slide.
Yeah, hover in the lower left over the slide and the little sort of invisible arrows should appear.
Well, I got the dual screen thing going, which is maybe a problem on my end. So let's see what happens now. Okay, sorry. Now you're seeing the second slide?
Yes.
Super.
So for those of you not familiar with NAMI New Hampshire, we are entering our 40th year as a nonprofit in the state. Grassroots organization started at the kitchen table of our founder, Peggy Straw. And our mission is to improve the lives of all people impacted by mental illness and suicide. We're not treatment providers. We do that through support, education, and advocacy. So the pandemic impact on mental health has been pretty varied. And I want to start by, saying that it really started early on. And when I say early on, in those first 3 months before the emergency was declared, there were already significant increased reports of anxiety, stress, and depression. And that's New Hampshire data through the TEMPSIS, and I can never quite remember what the TEMPSIS stands for, but it's something emergency medical services. So it was ambulance calls and whatnot. And then obviously March 15th, New Hampshire declared the state of emergency. And that threw the mental health service delivery system, like other systems, into a lot of uncertainty and chaos in the, in the week or two that followed, with trying to figure out all those things that I think we were all trying to understand about COVID and how it impacted, how it was transmitted, what safety precautions were needed. And particularly for, as we converted to a virtual world, for people that were reliant on direct service professionals coming into their home, case managers, assertive community treatment teams, mobile crisis response, and particularly for those that some who had people providing medications twice a day to them. There were significant special populations within those groups, such as people with thought process disorders, paranoia, people wearing masks and all kinds of protective gear, very upsetting and disquieting for them. What to do with our homeless folks, many of whom had severe mental illness, and the potential for widespread COVID contraction in those homeless camps, and also for people with co-occurring disorders and concerns relative to overdose rates and addiction and all of that. And then, you know, along those lines, like other areas across the workforce spectrum, there were significant workforce shortages, COVID related and non-COVID related. And some of those shortages existed prior to COVID. Certainly prior to COVID, the community mental health system was reporting close to 250 vacancies, of which the majority of those were clinical vacancies, and that was across the state. And, you know, and that's just a part of the system, but that's the core of the community-based services that serve our most severe population with mental health conditions. And then we start adding in all the COVID-related workforce shortages about people being exposed and having to isolate, or people contracting COVID and needing to be out of work for a period of time, and or their family members, and that all added to challenges related to delivering services to people with serious mental illness during that time. You know, one of the challenges that was still significant because of those workforce shortages was significant wait times for outpatient services. And I'll say a little bit more about inpatient and obviously emergency department boarding in a minute. But, you know, one real silver lining was the change of regulations at the federal and state level in allowing telehealth. And that was an enormous benefit. Mental health centers and other providers saw significant decrease in their cancellation rates because people no longer needed to worry about transportation or childcare or work issues. Of course, there were challenges with telehealth too. Some people didn't have access to computers, and so audio only was fine. But you know, we were aware of people having their calls with their therapist or mental health provider, taking it in their bathroom or in their car, because that was the only place where there was privacy in their home. And with kids home from school and whatnot, that was a bit of a challenge. And then significant impact on residential programs and services. And that compounded a lot of other issues in terms of, again, how do we keep people safe? What do we do about staff, exposures, and then closing down for a lot of some residential programs, and or stopping taking admissions, which had a significant impact on the emergency department boarding crisis. So I want to show you this slide, and this is data related to emergency department boarding. And those of you not familiar, it's essentially people waiting to be involuntarily admitted for the most part, although we'll put a fine point on that because there's not necessarily a voluntary admission process in New Hampshire. But what we're looking at is from April of 2015 through the end of April of this year, or the middle of April of this year. Thought I had a more current one than that. But if you look at the red arrow there, you can see the precipitous decline in people waiting. And that's at the point that the pandemic was declared. And, you know, people stopped coming to emergency rooms. I mean, there was just this, everybody was kind of under lockdown. And then, you know, what you see from that is a slow spike. The black line is adults, the blue line is children. And you see significant increases, adults up into the 60s, And that one spike for children was on Valentine's Day of this year, when there were 51 children waiting in emergency rooms, and just heartbreaking. And, so, some of that was that emergency department boarding was, those numbers had been coming down prior to the pandemic. At the point that the pandemic was declared, there was a planned transfer of all children from New Hampshire Hospital to Hampstead Hospital, and that was accelerated. And then we had a period where there was no reporting of children's data during the end of March and early April. But by the beginning of April, we started to see this slow increase that you just saw from the chart. And then in May of this year, we had the Jane Doe Supreme Court decision, and I won't get into that, but essentially saying that adults were required to have due process hearings within 72 hours. And we saw those numbers come down. And as of a couple of days ago, the numbers were back up a little bit, 12 adults, and again, 24 children, just heartbreaking. So some of the equity issues related to, or other related issues to the pandemic for people with severe mental illness was that, once again, we saw that that people with mental illness were just passed over in terms of, this emergency department boarding crisis had been going on for many years now, 8 years, 9 years. And I think the most obvious example is, and what's lost on people, is that those people waiting for inpatient admission, most of them have a life-threatening condition at that point. Most of them have serious suicidal intensity, or perhaps homicidal intensity, and that's the criteria for those admissions. So. But we were, as a state and as a country, able to set up COVID surge centers while significant numbers of people continued to languish in the emergency rooms. It also, related several other types of concerns, where now people in those emergency rooms were perhaps more likely to be exposed to COVID. Do they then bring that into an inpatient setting when they're admitted? All of those types of challenges. And then, relative to vaccine distribution, people with serious mental illness were originally kind of included as a prioritized population in the first draft coming out of the State Disaster Medical Advisory Committee. I don't remember exactly where they were. It was 1B or something, but in a later iteration, they were dropped down a step. We did advocate, and as a result of that advocacy, New Hampshire Hospital and some of the other inpatient facilities did receive the first round of vaccinations for staff. And again, that was really important given what was going on in the emergency rooms. And then, as I mentioned, I think for folks with various abilities or who require direct support professionals, they were really challenged during the first few months of COVID in terms of whether those people were going to show up to work, or were able to show up to work and provide them with the necessary supports that they need. And then I mentioned the impact on people with thought process disorders, and still a significant challenge for them when we get to issues of vaccinations, and trying to explain to them the importance of that, or that there are some people with mental illness that have received injections that find needles very untenable for them. Likewise, for some people with previous addictions. And then, a little bit unknown, but there appear to be some high rates of mental health issues for the so-called long haulers, for people that did have COVID. And then, I think the biggest thing that we're facing right now is that we really don't know what the future long-term impact on mental health will be for this period of the pandemic. And while we've seen it across the lifespan, I tell people that my dad, who is a very positive person, that in all my years, I never heard him say anything negative about the Red Sox. At the most, he would say, "I don't want to talk about it," quote. And this year, by February, he was just trashing the Red Sox coming into spring training and whatnot. And I think it was just reflective of, he was in an assisted living facility. He had been locked down. His mental health was not good. So we certainly know that those mental health impacts have been seen across the board, I think particularly for older adults, but very concerning for youth and young adults in terms of what they may have lost developmentally or academically during the past year. And just, kind of a reminder that about giving hope to people, and that's a lot of what we try to do at NAMI New Hampshire, giving hope and help. And then these are some resources that we have, and I'm happy to answer any questions.
And Ken, thank you so much. If people have questions, they can put them in the chat or come off mute and share them with Ken. There is one, I did see a question from Corey Rice, which is, are these numbers based on ED visits related to mental health? So I'm not sure if you can maybe scroll back to your slide.
Yeah, they're not, thanks for the question, Corey. These are not ED visits. They are, I don't know, it's not letting me scroll back. There we go.
There you go.
These are, so many people that come to the emergency room, those visits are assessed, receive some type of services, and are released. These are folks where after that assessment, the determination is made that they need inpatient care, and they're held, many of them involuntarily, waiting for inpatient care. And this is on any given day, the number of people being held in emergency rooms across the state. It's data provided by the Department of Health and Human Services, which I think really speaks to the transparency we have in our state, and that people are working together to try to understand and resolve these issues. So yeah, so not visits per se, but people who have been assessed as needing inpatient care.
Thank you, Ken. And there is another question from Holly Stevens in the chat, which is, what can this group do to assist NAMI in supporting folks through the end of the COVID emergency?
Thanks for that question, Holly. And, I think that continuing to be advocates across the board for people with severe mental illness is really important. I mean, the budget certainly contains a lot of very positive measures across the board relative to whether it's mobile crisis response statewide. I mean, other things that were priorities in the mental health 10-year plan. And I think just as you're in your work that you do, and particularly from a public health and an equity perspective, talking about mental illness as a population that is often people with severe mental illness have faced considerable discrimination and prejudice over the years, whether that's incarceration rates or homelessness or whatever. And and I'm not really focusing today on people of color, but we'll say that that's kind of compounded for people of color, and that then when you add things like historical trauma in there and other things, it just yeah, there's a lot of work to be done.
JJ, do you have your hand raised?
I do. Hi. So Ken,
Hi, JJ.
We have a huge mental health provider that's often neglected, which is the state prison and the secure psychiatric unit, but not just the secure psychiatric unit. And in terms of vaccine hesitancy, do you have any knowledge of how people are working on that within that situation?
It's a great question, and I don't have any information on that. I will say that we're in the in the midst of a significant training initiative with the Department of Corrections, which we're pretty excited about. And that's, ranges from trauma-informed care to crisis intervention team training, mental health first aid, several different programs. So with the team there, I will also say that, that Commissioner Hanks did a pretty outstanding job of keeping COVID out of the prison for quite some time in New Hampshire. She was on top of things back in January and of 2020, monitoring things very closely. But I don't have any information relative to vaccination and what's happened in the correction system.
Thank you. I don't see any more questions. I do see a recommendation from Corey in the chat. If you all want to check that out, Corey, I don't know if you wanted to say anything about that.
Sure. Yeah, so Dr. Christine Montrose, I actually, she's a good friend and a fellow born and raised Hoosier, so Indiana person. And that book is just amazing. And she actually works as a psychiatrist at within the prison system in Rhode Island currently. So I just highly recommend it. And I did have another question, if that's okay.
Yes.
All right. Ken, thanks so much for being here this morning. So you mentioned briefly that New Hampshire doesn't necessarily have a voluntary psychiatric hold. Could you explain that a bit more?
Sure. Thanks for that question, Corey, because it's really important. And it's something that the commissioner is about to address through emergency rulemaking. So after the Jane Doe decision requiring the state to provide due process hearings within 72 hours, the governor issued an executive order 48 hours later to allow emergency rulemaking. But let me back up a step and say that there is, like other parts of the country, a shortage of inpatient psychiatric beds generally. And just from the history of New Hampshire, if I can step back another step, that when the new hospital, which is now 30 years old, was built or opened in 1990, the planning for that was it was going to be a 200-bed acute psychiatric service, acute meaning short term, and that there would be designated receiving facilities or DRFs in local communities that would take most of the admissions in order to keep people near their homes, their families, and their communities. And that started to happen, but then, over the next 10, 15 years, many of those closed down. And then private psychiatric hospital beds started to dry up as well. So some people, and I've not been able to get any clear data on this, but some people that go to the emergency room in a mental health crisis who perhaps have had a prior hospitalization or who feel unsafe and feel that they're not able to be managed safely in the community. So seeking admission, the only way for them to be admitted is to go through an involuntary admission process. And that has all kinds of, again, negative attitudes, and I'm not a fan of the S word, the stigma word, but, associated with it. And would also say that, that for people with commercial insurance, many of them have that these insurance providers are supposed to be providing adequate networks of care, and they're not, and they haven't for years. And so they or their employers are paying, presumably, so that if they get ill, they're admitted to a hospital, and instead they're spending weeks, sometimes in an emergency room, waiting for a hospital bed, when they're voluntarily saying that they want to go to a hospital. So kind of a long-winded answer, but that's the situation as it stands right now.
No, thank you so much, Ken.
Thank you, Ken. Let me just take a quick scroll through and see if there are, there's all kinds of
Chris-
conversation in the chat. I don't see any questions. Does anybody want to, and I don't see any other hands raised.
Kristen, I'm
Um,
trying to figure out how to get my hand raised quickly. I did have a follow-up.
Okay, go
I'm
right
like,
ahead, Holly.
I had a follow-up question to what Ken just said, and I wanted to know, is one of the big problems that New Hampshire cannot involuntarily place somebody outside of the state lines. So as soon as they become involuntary, that becomes an impossibility. Is that correct?
Yeah, I guess, but I don't think that that's the issue as much as that there's just the lack of and so years ago, New Hampshire Hospital did take voluntary patients. And it's only sort of after the private psychiatric hospitals and and the other hospitals closed their inpatient units and those voluntary beds dried up that New Hampshire Hospital sort of exclusively now takes involuntary folks. So it's kind of complicated. I mean, there are some interstate compact transfers and those things for involuntary patients, but that's typically after the person has been hospitalized in their state. I mean, maybe maybe somebody from New Hampshire was hospitalized in Vermont and they need further hospitalization, and the interstate compact would allow them to be transferred. But I think I'm getting a little bit into the weeds there. And I do want to mention that Carol Totsky in the chat had indicated that that there are vaccines available for all staff and inmates at our correctional facilities. Thank you, Carol.
Okay, not seeing any more questions. I'm going to thank you on behalf of everyone here for all the great information, Ken, and for taking your time to come and speak with us today. And we welcome you back at any time. And this was really important to hear. So thank you so much. And with that,